All right. Hey ho, let's go. This is Resistance Radio, where natural selection selects resistance, but bad policy selects outbreaks. So today, let's talk about what's driving the headlines this week, because if you just skim them, you might think you're dealing with a handful of unrelated issues. Ebola in Central Africa, hantavirus exposures on a cruise ship, debates about vaccine safety, and a quiet push for access to massive amounts of personal health data. But zoom out and a pattern emerges. These are not just biological events. These are policy outcomes. Start with Ebola. Right now, hundreds of confirmed cases are being tracked in the Democratic Republic of the Congo and neighboring countries. But here's the number that should stop you. Only 45% of contacts are being followed. And outbreak control, that's like trying to put out a house fire while ignoring more than half of the burning rooms. You do not get ahead of an outbreak that way. You end up just chasing it. And why is this happening? It's not because we don't understand Ebola. We know how to control for it. For decades, we've been doing rapid testing, contact tracing, community trust, and resourced health systems. So what's missing is investment. Global health infrastructure is chronically underfunded in the exact places where outbreaks are most likely to emerge. Not coincidentally, those are also the places with the least political and economic power. When diagnostics lag, when surveillance is patchy, when health workers are under resourced, pathogens get a head start. That's not bad luck. That's actually called neglect. Now, layer on top of that the geopolitical response. The US is building a quarantine facility in Kenya, despite local protests and even court orders. Think about that dynamic. A high income country exporting its containment strategy to lower resource setting rather than investing long term in local capacity. That raises a fundamental question: who is public health for? Because the answer because if the answer is primarily to protect wealthy countries from imported risk, then we're not practicing global health. We're practicing border control with a medical veneer. Meanwhile, back home, we're seeing a different kind of policy tension, a push to access large scale medical records to investigate vaccine autism claims that have already been extensively studied and debunked. Let's be clear, large data sets can be powerful tools, but using them to revisit settled science, especially in ways that may undermine public trust, well, that has consequences. We are already in a moment where vaccine hesitancy is rising, driving less by driven less by lack of data and more by fractured trust. Physicians are reporting that conversations with patients are no longer just about evidence. They're about fear, identity, and credibility. And when leadership signals that foundational science is still up for debate, it doesn't clarify, it destabilizes. And at the same time, we're seeing shifts in global programs like PEPFAR, which has saved millions of lives. Moving toward an a la carte model may sound efficient, but it risks weakening the very infrastructure that made those gains possible. Public health does not work well as a menu of optional services. It works when systems are strong, predictable, and equitable. Even the quieter stories are pointing in the same direction. WHO estimates puts foodborne illnesses at 866 million cases annually, with about 1.5 million deaths. That's roughly 1 in 10 people on Earth getting sick each year from something that they ate. If that were an infectious outbreak with a novel pathogen, it would dominate every headline. But because it disproportionately affects low resource settings and because it's tied to food systems, regulation, and labor conditions, it fades into the background. Again, not biology, but policy. So what ties all this together? Outbreaks are not just about microbes, they're about decisions. Who gets funded, who gets protected, whose data is used, and whose lives are treated as expendable externalities. When we underinvest in global surveillance, outbreaks grow. When we politicize science, trust erodes. And when we prioritize containment over equity, we repeat the same cycle. And the cost is not abstract. It's measured in delayed diagnoses, overwhelmed clinics, preventable deaths, and in the widening gap between those who are protected and those who are exposed. If we want fewer outbreaks, we need fewer policy failures. This means investing where risk is highest, building trust instead of undermining it, and treating public health as a shared global good, not a commodity. Because pathogens exploit inequity with remarkable efficiency. And until we fix that, resistance won't just be microbial, it'll be systemic. So this is Resistance Radio, where the real epidemic is indifference and the cure is justice. My name is Mark Allen Derry. Again, this is Resistance Radio. Thank you for tuning in.